So today what I'd like to talk about is some of the telemedicine interventions that have been implemented around rural stress. Being a psychologist, a lot of my examples are telebehavioral health examples, but I think you can extrapolate to some of the other specialties as well. I want to talk a little bit about telemedicine and telehealth related to healthcare provider stress, and particularly talk a little bit about Project ECHO and the community of practice, and then finally talk a little bit about how you start a telemedicine program and encourage you to utilize your telehealth resource centers. So I'd like to really think about telemedicine and telehealth as a piece of outreach and really thinking about it as part of community engagement. And just like we think about any engagement, it's really on the foundation of trust and relationship. So I'll talk a lot about telehealth, and that's kind of the sexy part, is the technology. But the reason that our center's been around for 27 years is it's really leveraging the relationship and the relationship with families across our services. And what you'll hear too is the telemedicine treatment is fantastic, but as we start a telemedicine treatment, it's a chicken and egg. Almost the next thing that comes along is, I want more education. How can I recognize warning signs? So how can you pair the educational functioning, the mentoring functioning, and the treatment functioning with the telecommunication, telehealth technologies? So this kind of speaks to what I was mentioning before. Healthcare has changed. And in the 20 years I've been providing services, better, faster, cheaper technologies, convenient technologies, all that's fantastic. But again, just really thinking about how we're translating our best evidence-based services in relationship to the new technology-based setting. I'm going to talk about especially live video conferencing, so that component of telemedicine. Part of that's for reimbursement. That's what we've traditionally been reimbursed for, so that I have more experience in that area. But again, reimbursement is expanding to some of the other areas. When we talk about telehealth, it's really the larger umbrella where we have telemedicine, store and forward telemedicine, remote patient monitoring, mobile health, and e-health. And again, more and more, it's just getting to be healthcare. It's kind of more what people expect is the options to have both in-person and telehealth, telemedicine services. Potential benefits of telemedicine: there's family benefits. Being able to stay in your local community and have that support of primary care, family, friends, caseworkers, not having to drive 6 hours to come into the academic health center, it really benefits for the family. Improved healthcare access, reduced unnecessary patient transport, enhanced care coordination, addressing provider shortages, which we'll talk a little bit more about in just a minute, reduced provider travel time, and again, that going to retaining providers as well, retaining patients locally, and then also reducing provider isolation. Why so much telehealth now? Again, partly it's due to strong consumer demand across telemedicine services. I was watching some TV when I got in last night, and there were probably about 4 commercials about direct-to-consumer telemedicine services. There's health reform reasons that are really driving the tidal wave of telehealth. So changes in some of the regulations driven by the opioid crisis and trying to open up access to opioid use treatment services. There's health reform related to overall information technology, and also the shift to value is really driving some of the interest in telemedicine and telehealth. We've got reliable, secure lower cost technologies. There's been a lot of VA and military investment, so that's helped get some of the data that we need to look at and make sure that telemedicine is delivering high quality service. There's more telehealth provider networks. There's more federal resources to promote and support telehealth. And then there's growing opportunities across different sites of service, primary care, schools, in-home, and really across geographies. More states have telehealth reimbursement, so 49 out of 50 states now have a Medicaid policy that supports telehealth reimbursement. More states have parity laws. So with telemedicine parity, what that means is if a service is covered on site, then it's the expectation it'll be covered over telehealth and telemedicine. Now, it doesn't say it has to, some states do, some states don't say it has to be reimbursed at the same rate. And each state kind of has its own quirks in what that looks like. But it has been a help that more states are having regulations and information around telemedicine parity. And then also really looking at some states expanding down to home-based or telemedicine in unsupervised setting. So when you hear that unsupervised settings, when they talk about that in telehealth, it just means to the home. There are some exciting updates in telehealth reimbursement coming up in the next year. There's been expansion of CMS with virtual health, supporting some things including virtual check-ins, some remote evaluation, and the patient being able to submit video and other image, and also interprofessional specialists to primary care or other interprofessional consultations. There's been some expansion with clarifications in telehealth and acute stroke, so being able to do telestroke across geographies. And then with the Support Act, really there's been some good clarifications about how to support telesubstance use disorder treatments. There's also a growing empirical foundation for telemed. So the current state of telehealth, a new article was just released this month, again really showing that with the evidence we have, especially with telebehavioral health and telerehab, that we're able to provide the same level of quality service as you would receive in an on-site clinic. A lot of that, of course, depends on the thought that's put into the telemed service, where it's really thinking about how do I translate the best parts of treatment to the telehealth setting. And then there's more professional guidelines about telehealth practice. Telemedicine really can address core health concerns around accessibility. So this is the view outside of the window of one of our telehospice providers. So just thinking in the spring in Kansas, you get a lot of mud and a lot of challenges to get to sites. In the winter, you get a lot of challenges. And with this particular hospice, they're covering 16,000 square miles across 16 counties. So the telehealth has really been a great option to reach more of their patients and caregivers. It's increased availability. We'll see in a minute the health professional shortage area maps and just the real challenges in having behavioral health specialists in rural communities. And then also telehealth sometimes can give that anonymity. For example, we'll talk a little bit about telemedicine in schools, telemedicine in primary care, where it can decrease some of the stigma about reaching out and receiving services. I imagine you all have seen the health professional shortage areas map before. This happens to be the mental health shortage area map. Of course, a similar one with primary care, really speaking to a crisis and being able to have enough providers to meet the behavioral health needs. The top map is Georgia, so it just really shows, there's shortages in most areas except in the urban areas. And then the bottom map is Kansas. So except in Wichita and Kansas City, 100 of our 105 counties are mental health professional shortage areas. There's a couple of different models that are with telemedicine. So I've talked mostly about the supervised setting, as I mentioned. The home-based setting, it has some exciting opportunities. You can really catch folks where they're at. But with that, you also have to think, are you able to provide still the same quality of service? So really thinking through and crossing the T's that the provider on the other side is still has the level of training and is well equipped to deliver high quality service. The direct to consumer is also one you have to think quite a bit about with what's the safety in the home setting. So thinking about safety plans ahead of time. I know we just heard about thinking through working with your sheriff's department, working with your clergy, and thinking those through ahead of time before you have someone being seen over telemed and then needing more crisis services, so having those plans in place. At the heart of telemed is really thinking about the patient safety and then balancing that out, increasing access and providing the same high quality care. I'd like to think about some of the examples in terms of social determinants of health and really thinking about how telemedicine can help bridge the gap with some of the challenges that families face in receiving services. With that, I wanted to mention, I know we heard that wireless access, that one should be added, I think, as a social determinant of health as well. And some of the gaps in having high-speed internet connectivity. So with this first one, really looking at transportation barriers and provider availability, one of our projects is Telehealth Rocks, rural outreach to children in Kansas. I wish I had thought of that, but I think it's a great thing to really talk about some of the excitement and enthusiasm with telehealth, especially when you're working with children and their families. We're working with an area and 30% of children are living in poverty and trying to figure out ways to make the behavioral health care accessible and something that really fits the needs of the child and the families. What we see is that there are a lot of delays to seeking services. So when children are coming in, they may be coming in with a lot of comorbidity. You know, you were not catching the ADHD early. It's where the child struggled with a lot of other academic and social challenges. So really thinking about how those delays to treatment may impact the needs and making sure that you've thought through, you know, how often can I see this child, making sure that you can deliver the dose of service that is going to be the most helpful. The other thing that we really found with Telehealth Rocks is preparing in advance for trauma-informed care and making sure that, again, hand in hand, we're training around trauma-informed care using the distance education part of the technology at the same time that we're delivering services to children and families. I think it's hard to capture some of the enthusiasm kids come when they are being seen and really kind of bringing in that fun part. You know, it's the virtual high five, talking about the K-State or KU sweatshirt, or doing those same things that you do in person to really put the child and family at ease. And just, again, having that connection with them and their caregiver. This is just similar to what we were talking about before, where just the amazing amount of square miles being covered by different providers and thinking about how the technology can help meet some of that need. We really emphasize that telemedicine isn't half service, so it's not kind of therapy or kind of med management, it's really trying to approximate all the same elements as face-to-face care, or in some settings, like the school-based settings, trying to encourage that care coordination that's real system change. We think through the individualized behavioral health decisions, thinking through the child's developmental stage, the parent's preferences, the resources at the patient site, and then of course we defer to the provider's comfort level. Different services through telehealth and ROC schools. We deliver family and behavioral health therapy, so parent-child interaction therapy, different psychological strategies for behavioral concerns, trauma, and managing chronic conditions such as diabetes, asthma, behavioral strategies for autism and comorbid concerns. We do medication management and consultation. We do a lot with parent training and prevention. With our parents training, we're really pairing some online training for the parents. So there's different modules about behavioral management, and then in the telehealth session, the family and child are really supported and coached through the behavior therapist on the screen. We do assessment over telemedicine. So with autism assessment, it's really not just the child and parent on the other side, it's the whole school team helping with the evaluation. And then on the telemed side, it's another whole team where it's the developmental pediatrician, the psychologist, OT, speech therapy, all those coming together to make the autism diagnosis. Other clinics address feeding and weight issues, so we have a telefeeding clinic, some of the cutest kids, where it's really working with the child and family to assess the feeding concern. And then on the other side, with pediatric obesity and using the telehealth delivery for both group and individual sessions to help give the family skills in a healthy lifestyle. And then one of our popular clinic is our toileting clinic, and this really is driven by the school nurse's concerns. They came to us and said, you know, what we see is as kids in our school are being teased, they're going to be picked on for having toileting concerns. So it's a very behavioral clinic, and you see such progress where we've had kids who, you know, weren't even being allowed to come to school anymore. We're working with the psychologist and the school team to address the toileting issue. It helps get them back in school, and then of course paired with some of the social skills and other supports to help them thrive in the school setting. So that's with telehealth rocks, that kind of goes into addressing some of the social determinants with telehealth rock schools, where it's trying to bring systems of care together, where the school has seen that child over time. The teachers can comment, this just is not the kid that I knew before, and the school can bring that perspective paired with the parent-child perspective, and then collaborate with the specialist over the video conferencing to make the best plans with the team. There's real advantages with the telehealth part because you can all meet together. So instead of playing phone tag or trying to figure out or have the parent in a stressful situation trying to coordinate everyone, you can meet together and be on the same page. So school-based telemedicine, it answers the call in a new way. And the school nurse has really been our linchpin, linking patient guardian, the education system, specialist in primary care. We're really looking at in the past we've utilized schools that have the school nurse's office, so now we're partnering with some of our FQHCs that have school-based health center right there in the school. We don't have very many in Kansas, so we're really just getting started, and that's been very helpful just in terms of the level of support that the school-based health centers can give. Again, some of the rationale with school-based telemedicine, the youth tend to accommodate and like the technology. It's a safe, convenient place with trusted personnel and a whole team that's interested in the child's well-being. It can really thinking through how you speak both the school and the behavioral health language and focusing on how it really does help the child stay healthy and ready to learn at school. It provides many families a point of entry into health and mental health care systems, so they really trust the nurse to say, hey, this isn't a scary thing. It's just someone talking to you and wanting to help you over the telemed system. So that nurse is such an important part of the team in talking about what to expect in the meeting, helping all the way through from the paperwork through the telemedicine encounter, and then the follow-up, really helping the parent and child with following up on the recommendations and referrals that make sense within the local community. This just reflects that it saves a lot of travel time for families. With the Healthy Schools approach, this is more looking at healthy lifestyle intervention, where it was a group of families at the rural site that connect up with the behavioral psychologists, the nutritionists, and the physician to help with the intervention around healthy lifestyle. And they've got some good results where it's not just the immediate healthy lifestyle weight loss, but maintaining that over time. We really tried to tailor that based on focus group information from the families too, about what additional things are topics of high interest, and then really trying to make sure the intervention was meeting the family needs. Some of the newer approaches that we're investigating look at home-based telemedicine. So really looking at how that can address several of the social determinants of health, and really opening the access door a little bit wider. Different home-based telehealth projects that have been successful. One is iCare and MConnect. So with this project, it's really looking at families across the country where significantly ill folks on home parental nutrition connect with their caregiver and then participated in a facilitated support group. And my experience with that is, get the group started and get out of their way. They want to talk to each other. They want to share successes they've found, share practical tips about organizing their materials, coping with depression. It's really been a great experience in seeing how much family-to-family support can be achieved over the telehealth system. With that too, that particular project has decreased the reactive depression and also the infection rate among participants. I'll talk just a minute about mom health, and I want to make sure I do mention I Am Healthy, because we just kicked off the new I Am Healthy groups last week. And so with I Am Healthy, it's looking at delivering healthy lifestyle with a group right to the home. So for example, we'll have the child bring something from the pantry, and then we go through kind of looking at the food label all together, and as a group trying to come up with ideas about healthy lifestyle in the community. It's been really neat, again, the families sharing tips with each other. What day is the produce at a cheaper price at the store? Those kinds of real practical things have been helpful in those groups. With mom health, it's looking at, with pregnant and parenting teens, delivering iPad intervention. So this one includes both one-on-one coaching over the iPad, as well as the group-based intervention where teens meet together and then support one another. So with the Mom Health over the iPads, it's looked at delivering support around breastfeeding, healthy lifestyle, and depression prevention. We found that overall it's been successful. The biggest challenge has just been working into the very hectic lives of the teens. One area that is expanding quite a lot, we haven't done as much in this area in Kansas, but I know it's expanding across the country with substance use treatment and telemedicine, so I just wanted to touch upon that. SUD has increased 20-fold from 2010 to 2017. There's been new guidance from the Health and Human Services about MAT treatment and prescribing over telemedicine. I don't know how many folks are familiar with the Ryan Haight Act. It was really regulation meant to address online prescribing where there's no relationship with the person at the distant side, but it has impact on telemedicine. There was supposed to be developed a registration system for telemedicine providers that hasn't yet been developed. So with the opioid crisis, there's been more push to develop that registration system where telemedicine could fill the gap and offer some of the tele-SUD and MAT treatments over telehealth. Some of that's hot off the presses where with the Support Act for patients and communities, there is an expansion of some of the available services over telehealth. And then telemedicine with primary care, there's been some recent reports that it has been an area that's been slower to adopt than some folks were hoping, but it tends to be it's increasing slowly. Some of the challenges have been around reimbursement, and that's impacted some of the telemedicine to primary care. So it does look there will be some updates with telemedicine reimbursement within the FQHCs in the next year that may help with that adoption. What I hear when we talk with our rural primary care in Kansas is just really a concern about the relationship with patients and families. The local family physician just really wants to make sure that when they're encouraging or supporting the telehealth connection, that relationship with the patient is still going to be front and center. There's also concerns about complementing versus replacing services, so I think that is an important discussion to think about how telehealth can complement and support. There's also with primary care concerns about with the direct-to-consumer models. Boy, what if my patient is seen by a direct-to-consumer provider, a company, and then they get information over the night, and then they're back in my office the next day because they've tried something that doesn't work, and if there's not that care coordination, how will that be handled? So, I mean, there are models that address that by really trying to have the specialist in the primary care talk together and have those plans in place before seeing patients. There's new models emerging with integrated behavioral health in telemedicine settings, so really thinking about some of those brief consultations within primary care and really emphasizing some of the wellness kinds of things that we heard about earlier today. There's other things kind of emerging in primary care with telephone support models. So in my own world of child behavioral health, there's a lot of phone support models around child psychiatry. And if primary care has a kiddo in their office and they're not sure about starting the psychotropic, it's a way to reach out and have that consultation at their fingertips. There's eco-telemetry models, which I'll talk about in just a minute. And then there's also e-consultation between primary care and specialist. And then I added on one of our, I think, exciting project is called Behavior Checker. So the idea with Behavior Checker is parenting is healthcare. And just like you take a temperature whenever a young child's coming into the physician, you also take a behavioral temperature and see, are there tantrums, is there biting, all those kinds of things that can make you want to pull your hair out as a parent. And then really trying to link the information at the primary care with the best evidence-based kinds of things that we can offer, encouraging a lot of positive behavioral strategies, positive parenting practices. So we're rolling out the Behavior Checker in our largest rural FQHC in Kansas right now. And it's really trying to integrate into the EHR as well. And the telehealth part is more the ongoing telementoring with the staff, so they're able to connect up with the parenting specialists and get a lot of one-on-one feedback and case de-identified case consultation as they're trying out some of the information and the practices. I think it's also a really cool approach because it's linking up with the ACEs and ACEs training. So really trying to understand how ACEs impact our healthcare professionals. And with ACEs, it's looking at previous traumatic experiences and thinking about how that person's healthcare professional's experience impacts how they're able to work and assist parents in the practice. So more to come on Behavior Checker. Another area that we haven't touched upon is just using telemedicine and telehealth interventions for grief and loss. We hear a lot about using telehealth, of course, for depressions, for supporting suicide prevention. All of that's very important, but also trying to catch families earlier and help support around grief and loss and adjustment. So how can a counselor, a telecounselor, help with some of the same things that we just heard with helping support families as they think through financial losses. Telehealth has been used for teledisaster in a number of cases. How can it help with some of the grief and loss related to the larger elder population that we have in rural areas? There's been strategies to use telehealth with caregiver stress and really catching that caregiver at home and providing supports. How can it help some with change careers? Of course, coping with loss around a suicide, but also coping with loss around injury and change. And as many of you know, there's greater percent of folks in rural areas who have 4 or more chronic conditions. They're really coping with the chronic illness component, diabetes, asthma, all those sorts of health concerns. And how can the telehealth also help with the health psychology side, with adherence, and then also with just managing the chronic illness and the behavioral health components that may come along with that. Psycho-oncology is one that we've utilized more in that area. So we have tele-oncology, but then we're fortunate to have the oncology specialists work with the psycho-oncologist and really work as a team over the telehealth system. A few more healthy lifestyle kinds of interventions. I think I'm trying to say something similar, that wellness is really important and trying to think on that side of things. So we have things like kitchen therapy, where once a month the kitchen at the industrial kitchen cooks up a healthy recipe, and so now we broadcast that to different sites, and those sites also cook that same recipe. It's really more an engagement strategy to get folks talking about different healthy lifestyle approaches. We've done smoking cessation over telemedicine. Dr. Richard did one of the largest trials and found good outcome with smoking cessation. There's actually, it's an area that we really need a lot more work in telehealth. Not a lot has been done around smoking cessation, but again, the work's growing. healthy lifestyle, which we talked about. And then, of course, general healthy lifestyle, but also weight loss with chronic illness. The example is with our breast cancer survivors, delivering a group-based intervention over telehealth to, again, help with the social connection part. And that was a successful study. I want to talk a little bit about telehospice. I know I mentioned it before. Telehospice is also my chance to say the importance of a telehealth champion, and that really making the difference in telehealth programs. The Telehospice Project has really been driven by Sandy Coleman, the director of hospice in our northwest part of the state, where it's just always, well, why not? Why can't we do this? You know, and really just taking it and running with it. She tried an early telehospice project in the late 90s, and then Telehospice 2.0 from 2015 to present. In terms of cost savings for the hospice there, it's saving them about $2,500 a month in travel, which is really a meaningful impact when they're covering such a large area and, again, trying to reach as many families as possible. And with that, it's also been a morale booster for staff where they find they are connecting more often with one another and being able to support one another with the challenges in supporting families in hospice. It's been a good way for staff networking, team building, and then it's also offered other opportunities for mentoring and support. The Hospice Services, Inc. has run with professional-to-professional encounters, so using the iPad, for example, to connect with a wound care specialist, using it to connect social workers and the chaplain across that large 16,000 square mile area. They've used it for education, so connecting the hospice team back to our fellows lecture series at the Academic Health Center and really offering those opportunities for continued education. It's offered a way for patients to say goodbye with their families so that the iPads have been able to connect the patient with their children who may be in different states. It's been used to honor veterans with using the telemedicine to then connect to the senator's office and do pinnings to really thank and support the patient in hospice. Anyway, I hope what you see is that it's as creative as you can make it. Sandy thinks that she wants to do it. Boy, let's give it a try and see if it works, and often it has. I really like how she summarized it. You know, we're available to the families 24/7 and work on God's time, where it's really the technology is a tool to meet that overall mission. It may be scheduled calls, it may be tuck-in calls, it may be emergency calls. I know recently it was a patient saying, boy, can you just stay online while I'm going to sleep? All those kinds of supports have been incredible with telehospice. I'll just then talk a little bit about, it has a lot of opportunity with training and supervision. So really it's a win-win for our students to be able to connect with rural communities and hopefully get them thinking about, I can connect by telemedicine, or I may want to go and be on site and work in rural as well. We really think through a lot of the competencies with that, not just the clinical and technical, but also, of course, the rural cultural competencies. Telesupervision is another area that has been very helpful with folks who are out in the field, either as trainees or early professionals, being able to connect back and have support. And then finally, I want to make sure I'm mentioning Project Echo. How many of you have used Project Echo? So it's really a telementoring approach. So it's kind of like Brady Bunch on the screen where you see all the sites and then the interprofessional team in the middle. where the idea is folks can bring their own de-identified cases and they can talk through best practices. There's really brief didactics, but it's more the idea of developing a community of practice. It's been very successful. The idea is really that telecurbsiding idea where you're able to then connect and have that support across both the expert panel as well as peers. It's used across a range of participants and diversity of organizations. And really, again, the idea is to use the telehealth technologies to create a supported environment for the especially rural primary care provider. It's been used a lot with opioid use addiction, opioid use treatment, with pain management. We're using it a lot with child behavioral health. We're just finishing up our irritable child echo where primary care and school personnel have been on the same call, and it's just been a really good experience. I hope this has got you interested in telehealth. If you are interested, I'd really encourage you to think through our telehealth resource centers. The one here in Georgia is the Southeastern Telehealth Resource Center. Any resource center can help you or address questions. They're federally funded, so the idea is really just to answer whatever questions you may have about telehealth. So, thank you.